I think that hyponatremia is one of those topics that has a deserving reputation of being difficult and creating a sense of nervousness. It's like the Krebs cycle in a sense. It elicits the same kind of anxiety no matter how many times we review the algorithm. It never seems to stay in our minds long enough for the next time we need the information. And the more you look into it and try to understand it, it seems like it gets even more confusing and get lost in the details. So this video won't go over the hyponatremia algorithm itself, but rather go over some of the concepts that helped me set myself up to eventually better understand the underlying thought process of the hyponatremia algorithm. We'll go over these concepts one by one and then summarize at the end to hopefully get one step closer to feeling more comfortable with the next time you encounter hyponatremia. Just as a disclaimer, this video isn't exhaustive of all the causes of hyponatremia. So I'm going to start off first by just briefly covering the stuff we need to know in terms of normal kidney function in normal non-hyponatremic states, and this is probably stuff you already know, but it's worth reiterating because we'll build off of it. The first concept is that the kidneys work off of two signals that modulates its function, and those are aldosterone from activation of the renin-angiotensin and aldosterone system, or RAAS, and antidiuretic hormone from the brain. So basically, in broad strokes, if the kidney's perfusion is low, then the kidney's like, oh shoot, we gotta hold on to more water, and secretes more renin to trigger RAAS, which eventually increases water reabsorption in the kidneys. RAAS also triggers the brain to release ADH because of angiotensin II's activity on the brain, which also facilitates an increasing water reabsorption in the kidneys. But overall, just remember that decreased perfusion of the kidneys ultimately triggers both an increase in RAAS and ADH, which functions to reabsorb both extra sodium and water. And this all makes sense, right? Because if we're low on fluid, we want to reabsorb sodium and water at the right ratio to make sure that we are essentially reabsorbing isotonic fluid so that we get the volume we need and we don't mess around with the solute concentration. And usually in our bodies, we have a moderate amount of RAAS and ADH working to keep things in balance. The second concept is that when both ADH and RAAS work at full throttle, so not the moderate amount, but at full blast, we'll get a very high amount of water reabsorption and a modest increase in sodium reabsorption. And this is a situation where we're not just like a tad bit dry, but rather we're like really, really dry and our kidneys are really not getting much perfusion. The way that I conceptualize this is that our kidneys have a high sodium concentration difference as the urine is on its way out. So water, if it had a way, wants to really get out of the collecting duct and back into the body. Basically, the sodium acts as a driving force for water reabsorption, and the collecting duct is analogous to a high-pressure tunnel with faucets on the side where water can escape back into the body. The faucets, however, remain closed unless ADH come by to open them. Normally, when we're not super volume deplete, ADH levels are modest and there's a moderate amount of water reabsorption. But when ADH is working at full blast, the faucets are open all the way and there's a huge amount of water being reabsorbed. The faucets, by the way, are the aquaporin channels. Now, since we're working with an example of a volume deplete state, RAAS is also activated, which means that the epithelial sodium channels, or ENaC channels, are added to this picture and facilitates even more sodium to be reabsorbed so that the faucets have that extra boost of driving force for reabsorption of water. But again, the reabsorption is happening with a huge increase in water reabsorption and a modest increase in sodium reabsorption, which means that the net effect is that we're reabsorbing a hypotonic solution. Now, some of you may realize like, hey, wait a minute though, would ADH actually be on full blast to the extent that we'd reabsorb hypotonic solution? Because, well, there's the hypovolemia that's trying to increase ADH, but as we reabsorb hypotonic fluid in the kidneys, the serum osmolarity is going to decrease, which would be sensed by our osmoreceptors in our brain, which should decrease ADH secretion, right? So wouldn't it make sense that the competing factors of low volume and low osmolarity bring the ADH level to a more moderate level to avoid diluting the serum too much? And that's totally a fair point, which brings us to the third concept, which is that ADH release prioritizes volume status over serum osmolarity if the volume status is really, really low. So basically, our brain prioritizes making sure things are perfused adequately with good volume before making sure that the volume itself has the optimal solute concentration, which makes kind of sense, right? Because things will die if they don't get perfusion, while things may not work properly if the serum concentration is off. Both aren't great options, right? But in these extreme situations of severe hypovolemia, where the two interests are at odds, it's reasonable to prioritize volume. Now, if you understand what's being said so far, you actually know a lot of the hyponatremia algorithm already, specifically the ones for hypovolemic and hypervolemic hypoosmolar hyponatremia. For hypovolemic hyponatremia, it's exactly what we just talked about. Things like diarrhea or vomiting lead to decreased overall body volume, which means that the arterial supply to the kidneys is low, which means that the kidneys are poorly perfused and correctly determines that the body is volume deplete, which leads to ramping up of RAAS and ADH to full throttle and reabsorbing hypotonic solution, leading to hyponatremia. I won't really go into the specifics of treatment for this video, but you can see how giving some isotonic saline would help correct this because it corrects the underlying issue of poor perfusion to the kidneys. It's also important to note that in this case, the urine osmolarity would be high, and that makes sense, right? Because we're reabsorbing so much water, all the other solutes in the urine get really concentrated. But it's important to note that although the urine concentration of other solutes like maybe potassium, calcium, magnesium, and chloride are high because we reabsorbed a lot of water, we still have a low urine sodium concentration because we really worked hard to increase sodium reabsorption through RAAS. If the hypovolemia were driven by diuretics, we'd see all the same things of decreased kidney perfusion leading to upregulation of RAAS and ADH with hypotonic reabsorption leading to hyponatremia, but this time the kidneys have trouble reabsorbing sodium due to the diuretics. So what ends up happening is that the urine sodium level will not be low. However, otherwise, again, everything else is the same in terms of the kidney's response to sensing a low perfusion state. For hypervolemic hyponatremia, it's similar to hypovolemic hyponatremia because the issue is the same in that the kidneys are getting poorly perfused. In conditions like congestive heart failure or cirrhosis, there's low arterial volume because the body's fluid is mostly stuck in the venous system, which eventually seeps out to the extracellular space where it's stuck there as well. In any case, any condition that causes the fluid in our body to accumulate somewhere that's not in the arterial system to perfuse the kidneys would make the kidneys understandably think that there's a hypovolemic state going on. So then again, although the body has excess volume, because the only thing that the kidneys see is poor perfusion, it'll think that the body is in a hypovolemic state and treat it as such by ramping up RAAS and ADH to full throttle and reabsorb hypotonic solution again, leading to hyponatremia. And just like in the hypovolemic state, the kidneys make high osmolarity, concentrated urine, but with low urine sodium concentration. So now the next part is what gets people a little nervous and is the core of many people's anxiety, which is when you see hyponatremia, but the patient is euvolemic. And in these cases, the kidneys are getting perfused well, but they end up becoming hyponatremic anyway. So we can't explain what's happening with the thought process we were using earlier. And there are actually two overarching ways we can end up with a state like this, where again, the kidneys are getting perfused and thus the kidneys appropriately know the body has enough fluid, yet we still end up with a hyponatremic state. This actually brings us to the next concept, which is that it's possible to become hyponatremic if we take in so much more water than the amount of sodium we consume or have in our body, which is actually probably the most intuitive way to get hyponatremia. It's basically the scenario where the body takes too much water for your body and the kidneys to handle. But I want to be very specific by what I mean by too much for the kidneys and bodies to handle. You see, the whole RAAS and ADH mechanism to control the kidney's function is pretty smart. If we're in a normal volume state, RAAS is only active at a moderate level since the kidneys are satisfied by their perfusion, and ADH is also just moderately active from the moderate amount of angiotensin II, at least as long as the serum osmolarity is normal. But if you start drinking lots and lots of water, you're going to start to lower your serum osmolarity, right? RAS would be like, hey, I'm still happy since kidneys are being perfused, so I'll remain where it is. But the osmolar receptors in our brain are going to be like, hey, wait, we're diluting too much. And that would lead to shutting down ADH. Again, I want to just remind you that this scenario is similar to the hypo and hypervolemic hyponatremia in that the serum becomes hyponatremic, but unlike before, in this scenario, ADH is shut off because the perfusion criteria is satisfied and the brain is happy to shut down ADH to tend to the decreased osmolarity. So what happens when we take in a lot of water, and I mean like a lot, is that ADH shuts down and closes off all the faucets we talked about before, which means that our kidneys are not doing any concentrating of urine, which is another way of saying that the kidneys are producing the most dilute urine that it can. Now, the important thing to note here is the next concept, which is that the kidneys have a limit to how dilute it's able to make its urine. I won't really go into too much detail as to why, but to just quickly touch on that, the most dilute urine in our kidney is right over here before we encounter any concentrating effects from the faucets or aquaporin channels that are promoted by the ADH, right? So if we have ADH completely turned off, that means that the urine here, more or less, goes through the rest of the nephron without getting modified in terms of urine concentration, since we aren't reabsorbing any more water. That means the most dilute urine we can make is the concentration of urine up here, which is about 100 milliosms per liter in a healthy kidney. In diseased kidneys, by the way, we won't be able to dilute as much, so their urine concentration in this case might be a little bit higher. But anyways, the only thing that you really need to take away from this is that the kidneys have a most dilute urine it can produce, which means that there's a specific minimum amount of sodium that it has to expel along with water. If you take in a ratio of water to sodium that is higher than the ratio of the maximum water to sodium ratio that the kidneys can expel, you end up diluting your serum sodium with excess water. In other words, if you happen to take in any kind of drink, like just plain water, for example, that is more dilute than the maximum diluted urine that your kidneys can produce, you would end up decreasing your serum osmolarity. I think an example here would help illustrate this if my explanation wasn't that great and lost you there. Let's say that our kidneys can dilute our urine to 10 milliequivalents of sodium per 1 liter of water. Another way to look at this is that if we have 1 liter of water that we want to expel, we need to sacrifice at least 10 milliequivalents of sodium. An average American diet is about 3,400 milligrams of sodium per day, which is roughly about 150 milliequivalents of sodium. So if our kidneys are able to secrete a maximum of 1 liter for every 10 milliequivalents of sodium consumed, and we have 150 milliequivalents of sodium available a day, that means our kidneys can get rid of at most 15 liters of water a day. So even if you're drinking lots of water, like a ridiculous 15 liters of water a day, if you have healthy kidneys that can maximally dilute to 10 milliequivalents per liter of sodium, you can get rid of all that extra water with an average American diet. But if you drink any more than that 15 liters, like say 16 liters, every bit of water you consume above the 15 liters would contribute to diluting your serum sodium concentration since it can't be peed out. Now, let's say you're not eating an average American diet and instead go the total opposite extreme of barely having any sodium intake. Say that we decide to drink just beer all day, which has about 40 milligrams per liter of sodium, which is about 1.7 milliequivalents of sodium per liter. Well, you can probably already see the problem here that you're consuming something that has more water per sodium than maximally dilute urine, which we said before was 10 milliequivalents per liter. We'd have to drink about 6 beers worth of sodium in order to get rid of 1 beer's worth of water. The remaining 5 beers worth of water is contributing to diluting your serum sodium concentration. Now, I'm not promoting people to drink 6 beers in a day, but if you were to drink 6 beers in a day, you're probably eating other things and snacking on other things along with it, which gives you the extra sodium to be able to pee all that water out. This is the concept behind hyponatremia that we see with underlying psychogenic polydipsia and beer potomania or tea and toast diet. Basically, either there's an exorbitant water intake with normal sodium intake, or normal water intake with an extremely low sodium intake. The story is the same in that we took too much water for the amount of sodium we took in, so the kidneys are not able to handle it. To add on top of this, people with kidney disease can't dilute their urine as much as healthy kidneys, so the minimum sodium requirement to expel water would be higher, which would make them even more susceptible to this kind of scenario. Now, you may be wondering, why are these people euvolemic though? Because, well, with this relative excess in water that can't be peed out, wouldn't it make sense that they should be hypervolemic? And that's a totally fair point. I'm not sure if I can explain it that well, but you can see that to get hyponatremia like this, you'd have to drink an absurd amount of water or eat very little sodium or a bit of both. In either case, it's very hard to drink more than that absurd amount, and if you eat anything at all, it's bound to have a decent amount of sodium in it. So overall, our kidneys can work really hard to dilute and get rid of most of the water. And thus, clinically, you won't see someone retain enough water to really swell up and appear hypovolemic on physical exam. The blatant exception to this would be renal failure, where the kidneys again don't have the capacity to manage the sodium and water balances, which can lead to hyponatremia due to the reason that we just discussed for psychogenic polydipsia or beer potomania, but instead results in hypervolemia because the kidneys really can't dilute urine well, which leads to excess water retention. The urine sodium will be higher compared to what we would expect from a healthy kidney in the same scenario, hence the increased urine sodium. There's probably some hypoperfusion physiology going on, just like the congestive heart failure and cirrhosis, because renal failure can lead to proteinuria or loss of protein in the urine, and this would understandably reduce the serum oncotic pressure, leading to third spacing. So just like congestive heart failure or cirrhosis, the volume in our blood seeps out into other places, in this case the extracellular space, which reduces the arterial volume, thus reducing the renal perfusion. In any case, this would also lead to a trend toward hyponatremia, thus the two problems of hypoperfusion and the inability to dilute the urine well would both lead to hyponatremia. I hope all of this is clear so far, because next is our last concept we'll go over, which also falls into the euvolemic category, and it's probably the one that makes people's heads spin the most, because this is the syndrome of inappropriate ADH secretion, or SIADH. And don't worry, this should all make sense as long as we take it step by step. So we should first start off by making sure we are precise about what we mean by when we say SIADH. It's the syndrome of inappropriate ADH secretion. So what that's basically saying is that ADH is being secreted no matter what's going on in our body. There are many causes that potentially can result in the unconditional constant secretion of ADH, but we won't go into that list of things since I don't think it's exactly necessary to understand the overall mechanism, and it'll help kind of simplify things a little bit more. But anyway, just to review, ADH acts to open up those faucets or aquaporin channels to reabsorb more water and concentrate urine, right? So if ADH is being constantly released regardless of how the rest of the body is doing with fluid levels or sodium levels, what happens is exactly what you'd probably expect, which is that we start accumulating lots of water. Then the heart has to deal with that extra volume by doing more work to pump the blood forward, which it's able to do, which leads to lots of perfusion of the kidneys, which tells the kidneys, like, hey, we can ease up on the RAS, which then downregulates the extra sodium reabsorption in the collecting ducts through the ENaC channels. And that makes sense, right? Because we don't need any extra volume. We don't want RAS to contribute to helping ADH reabsorb more water. Now, usually the downregulation of RAS downregulates ADH secretion as well from the brain because angiotensin II would decrease, thus decreasing the stimulation to release ADH. But here we're in a diseased state where ADH is being secreted constantly, whether it be from brain or elsewhere like the lungs. So for the first time, we see ADH and RAS actually fight against each other and trying to accomplish opposite things. RAS is trying to reduce water reabsorption, and ADH is trying to increase water reabsorption. And remember how I mentioned earlier that the heart is working kind of hard now that we're teetering into the hypervolemic state from all the water we're reabsorbing from the constantly active ADH? Well, the heart says basically, okay, enough of this nonsense. You're putting too much stress on me, and starts releasing what are called natriuretic peptides like atrial natriuretic peptide, ANP, and B-type natriuretic peptide, BMP, which tells the kidneys like, hey, dump more sodium. If you reabsorb sodium, you're enabling ADH to reabsorb more water easier. So, before we swell up to be able to clinically tell that we're hypervolemic on clinical exam, RAS, ANP, and BNP fight against ADH to keep the volume to a euvolemic or slightly hypervolemic state. All the while, the serum sodium goes down because the increase in natriuretic peptides and decrease in RAS are encouraging sodium loss, and ADH is reabsorbing water. So now, what would the urine look like for this person? Pretty concentrated, right? With high osmolarity, and a lot of that osmolarity coming from high sodium, right? So with SIADH, you end up with a euvolemic to slightly hypervolemic state with hyponatremia and a concentrated urine with high overall osmolarity and a high urine sodium that contributes a lot to that high osmolarity. So some key points to summarize some of the conditions that we just talked about. So for hypo and hypervolemic hyponatremia, the key things to note are the kidneys work mainly off of two signals, which are RAS and ADH. RAS increases with decreased kidney perfusion. ADH also increases with decreased kidney perfusion. ADH decreases with low serum osmolarity, but prioritizes increasing in the state of kidney hypoperfusion. RAS and ADH at full throttle reabsorbs hypotonic solution. Increased RAS leads to decreased urine sodium unless diuretics are on board, which would increase urine sodium even in the state of increased RAS. Increased ADH leads to increased urine osmolarity, and it's possible to simultaneously have a decreased urine sodium and an increased urine osmolarity, since urine osmolarity is the total osmolar concentration of the urine solutes, and sodium is just one of those solutes. You can have a increased urine osmolarity if there are other things like the potassium, calcium, magnesium, bicarb, all those other things in your urine. The next group of concepts are good to understand the psychogenic polydipsia and beer potomania or tea and toast diet. And those concepts are that the kidneys are great at regulating volume and sodium, but they have their limits, and you can overwhelm them if you take ridiculously high amount of water compared to your sodium intake. You overwhelm the kidneys by taking a larger water to sodium ratio than the most maximally dilute urine that our kidneys can produce. And our urine sodium in this case is low because your body is struggling to hold on to sodium and only allowing the bare minimum amount out to get the excess water out. Urine osmolarity is low because ADH is completely off and not concentrating the urine at all. And lastly, for the group of concepts for SIADH, they are that there's some sort of constant ADH secretion that'll keep secreting even if it's screwing up the body with excess water reabsorption and decreased serum osmolarity. As a response to this, RAAS shuts down to fight against ADH's efforts to reabsorb water by decreasing sodium reabsorption. Natriuretic peptides, including ANP and BNP, come into play as we approach hypervolemia, and they also fight against ADH's efforts to reabsorb water by also decreasing sodium reabsorption. And urine sodium will be high because decreased RAAS, increased ANP, and increased BNP all work to dump sodium to decrease water reabsorption. And urine osmolarity will also be high because despite the efforts of RAAS, ANP, and BNP, ADH is able to reabsorb a lot of water, which concentrates the urine. And also, I wanted to leave you with one additional concept when thinking through euvolemic hyponatremic states, because I often get lost in the thought process. The concept that I default to when this happens is that I remind myself that if all the signaling in our body is working appropriately, our urine concentration should generally trend in the same direction as our serum concentration, right? And what I mean by that is that if we have a hypoosmolar hyponatremia, we should expect that we have dilute urine because our kidneys should be working hard to get rid of that fluid that's diluting the serum. If the urine for some reason is not maximally dilute in this hypoosmolar hyponatremic state, that should raise some flags that the kidney is getting some mixed signals and there might be an SIADH picture going on. And with that, good luck, and I hope it was somewhat helpful. See you guys. Bye.